Hey everyone, welcome back to IMG Dr. Diaries. Today, we're going through the presentation and management of pulmonary embolism, or PE. This is something that comes up all the time, whether you're preparing for the MSRA, MRCP, or just seeing patients on AMU or the wards. So by the end of this video, you'll know exactly how to spot PE, how we investigate it in the NHS, and how we start treatment safely. PE is one of those conditions that's life-threatening if missed, but actually pretty easy to treat if you catch it early. That's why it's such a core topic for both exams and day-to-day practice. All right, let's start with risk factors, because that's usually your first clue. I actually remember learning an acronym for this back in med school. It was thrombosis. It's not perfect, but it really helps jog your memory. T, trauma, like recent surgery, fractures. H, hormones, pregnancy, postpartum, HRT, combined pill. R, road trips, long travel, immobility. O, obesity. M, malignancy, active cancer. B, blood disorders, like thrombophilias. O, old age. S, smoking. I, immobilization again, long hospital stays, paralysis. S, sepsis, serious illness. So anytime you see these, keep PE high on your list. Next, the classic presentation. Sudden onset shortness of breath, pleuritic chest pain, sharp, worse on inspiration, cough, sometimes with hemoptysis. On examination, you might see tachycardia, tachypnea, hypoxia. And in a massive PE, they might be hypotensive, have syncope, or show signs of right heart strain, like a raised JVP. But always think about your differentials first. PE can easily mimic myocardial infarction, MI, or unstable angina, pericarditis, and sometimes even GORD in milder cases. So if there's any history or findings suggesting MI, like central crushing chest pain, radiation of the arm or jaw, or ECG changes, you'd obviously go down the ACS pathway first. Once you've ruled out MI, or there's no history or findings indicating it, and you're still suspecting PE, that's when you use the Wells score. In our trust, we use the simplified 2-level Wells, which splits into PE likely, score more than 4, PE unlikely, score less or equal to 4. So what actually gives you points? 3 points if there are clinical signs of DVT, like a swollen, painful leg. 3 points if PE is the most likely diagnosis, meaning there's no obvious alternative explanation. 1.5 points each for a heart rate over 100, recent surgery or immobilization, or previous DVT or PE. 1 point each for hemoptysis and active cancer being treated or diagnosed in the last 6 months. So if your quick total is over 4, that's PE likely, and you'd go straight to imaging. If it's 4 or below, it's PE unlikely, and that's when you move on to D-dimer. All right, so if it is PE unlikely, you do a D-dimer. But what actually is a D-dimer?
It is a breakdown product of cross-linked fibrin. So it basically tells you that there has been clot formation and breakdown somewhere in the body.
It is very sensitive. So if it is normal, it pretty much rules out a clot.
But it is not specific at all. It can be raised in infection, inflammation after surgery, or even just in pregnancy.
That is why we always use it together with the Wells score. The usual cutoff is less than 500 nanograms per milliliter.
But in patients over 50, we actually use an age-adjusted cutoff, which is roughly the age times 10. So for example, in an 88-year-old, the cutoff would be 880. Do not make the rookie mistake of thinking a D-dimer of 750 is positive in them.
It is actually normal for their age, and you would avoid unnecessary scans.
So if the D-dimer is below this cutoff, you have basically ruled out PE. If it is above, that is when you arrange a CTPA, which is our gold standard.
And here's the important bit. In real life, your CTPA might not happen straight away. It could be later that day or even in a couple days, depending on scanner availability. So if you have a high clinical suspicion, you do not wait. You start therapeutic anticoagulation immediately. In my trust, we use Apixaban, which is a DOAC also commonly used for atrial fibrillation. For PE, we give 10 milligrams twice daily for 7 days, then 5 milligrams twice daily thereafter. If it is a provoked PE, like after surgery, long flights, or hormonal triggers, we usually treat for 3 months. If it is unprovoked, or due to ongoing risks like active cancer, we typically go for at least 6 months and sometimes indefinitely with hematology follow-up. And finally, if your patient is unstable, meaning they are hypotensive, have syncope, or are in shock, think massive PE. This is when you call for senior help immediately, consider thrombolysis, and escalate to critical care. So, quick recap. Think thrombosis for risk factors. Look for classic symptoms, but always rule out myocardial infarction, angina, pericarditis, and GORD first. Use the 2-level Wells score, and remember what actually gives you points. If it is 4 or below, do a D-dimer with age adjustment. If it is more than 4, or if the D-dimer is positive, arrange a CTPA. If your suspicion is high, start anticoagulation immediately. Usually Apixaban 10 milligrams twice daily at first. Treat for 3 months if provoked, or at least 6 months if unprovoked. Hope that helps for your day-to-day work, your MSRA or MRCP prep, or just being more confident on call. If you found this useful, drop a like, subscribe, and I will see you in the next one.